We are now going to move to the next speaker, Bernard, Professor Bernard Allaouchiche from Lyon. Bernard is a professor of anesthesiology and intensive care medicine, and he's an expert in infectious issues in critically ill patients and antimicrobial resistance. His research combines both clinical and experimental studies on sepsis and microcirculations alterations, and he has recently developed drug dosing guidelines for obese patients. So we are looking forward to hearing from you, Bernard, on this very difficult but quite common issue of dosing adjustment in obese patients. So.
Okay, thank you, Claire. Do you hear me?
Yeah.
Okay? And do you see my my slides?
Not yet. I think you need to share your screen.
Sorry. Is it okay now? No?
Not yet.
The sharing is on. Partager l'écran. Ah, ok, partager l'écran. Sorry. Ah, okay, I see. Okay. And now is it okay? No, not yet.
No, but if you want me to share my screen, and then you can say next slide.
Okay. Thank you. Okay, thank you very much, Claire. So good morning. So I will speak about those challenges in obese patients. Next slide. So obesity is becoming a major burden on healthcare system because there is a high prevalence of obesity in the population. We have a lack of information about dosing antibiotics in this population. There are very few studies. And we also know that obesity is associated with increased morbidity and mortality in patients with sepsis, especially with bacteremia. And we also know that obese patients could present impaired immune function. So, next slide. So the situation is very complex. There is a high complexity of the septic obese ICU patient because these patients have an increase of volume of distribution. They present changes in renal excretion, hepatic metabolism. We can see that in some situations there is an increase of volume of distribution because of the excess mass, hypoalbuminemia, sepsis, edema. Some patients present a decreased VD because we can see that patients have a high renal blood flow, high glomerular flow rate, and some patients have a decreased clearance because they have acute kidney injury or a decrease of cardiac output. And next slide, please. So The first problem is to know which weight must we use. Can we use the ideal body weight, the total body weight, the adjusted body weight? And you can see the formula to compute this body weight. And it is very important at first to know the ideal body weight with a divine formula, and to compute for some antibiotics adjusted body weight or lean body weight. Next slide. So actually, there are approximately 30% of adults in Europe, between 20% and 30% of adults who are obese. And you can see the classification of obesity, and the most challenging situation is class 3 obesity, which is known as massive obesity. Next slide. So to summarize pharmacokinetic change in the obese patient, we can see that the absorption is modified. So this patient have often a delayed gastric emptying. The distribution is modified because this patient present an excess body weight, and we know that in the fat tissue there is 30% of water. You know that there are lipophilic drugs and hydrophilic drugs, and it depends. The distribution is associated to the nature of the antibiotic, and for some antibiotic we must use total body weight. For some other we must use ideal body weight or adjusted body weight. For the problem of the plasma protein binding, we do not know if how is it modified. Another problem is the renal function, because the classical formula don't clearly do not exactly estimate the renal function. So the better is to collect the 24-hour urine collection to really know the renal function. And at last, some patients present a diminished hepatic metabolism. Next slide. So the problem of hydrophilic and lipophilic antibiotics, you can see on the left that hydrophilic antibiotics, you can use ideal body weight or adjusted body weight or total body weight. We'll show this later. And for lipophilic antibiotics, we can use total body weight or adjusted body weight. Next slide. So I will give you some example for aminoglycoside. Most of the authors have written that we must use adjusted body weight or ideal body weight in case of obesity, and to avoid toxicity associated to a massive dose of antibiotics. And I have chosen to present a real case with a massive obesity, and the total body weight is 130 kilograms. The ideal body weight is 78 kilograms, and the adjusted body weight is at 96 kilograms. So you can see that the dose is not the same, and if we use 3,250 milligrams, is very. This must be a toxic dose. Next slide. So we have built. Sorry, it's in French, but we have built an Excel spreadsheet And in this spreadsheet, you enter data, the weight, the dose, and the computer calculates the ideal body weight, the ideal body weight, the adjusted body weight, and the lean body weight. And you can choose your dose, and you can see at the bottom that the dose for this patient must be approximately 2,400 milligrams. Next slide. So for the gentamicin, it's the same thing, and the adjusted body weight is calculated, and we use adjusted body weight to avoid an excess dosage. Next slide. We have realized an iPhone application. And next slide. And in this application, you can you enter the weight and the morphometric parameters, the dose, and on the left, you can see that the dose must be for this patient with normal renal function must be 2,400 milligrams per day. Next slide. For the vancomycin, most of the authors recommend to use the total body weight for initial doses, and so with the same parameters for this patient, we have calculated that we must use 3,900 milligrams per day. Next slide. For piperacillin tazobactam, some other things that we must use adjusted body weight and prolonged infusion, but with this method, the toxicity could be present, and most of the authors think that we must avoid to, and the cap is at 24 grams a day, but we know that the usual dosage is not sufficient to treat patients with high MIC bacteria, but we must navigate between the good plasmatic levels and toxicity. Next slide. For cefepime, all the intensivists know that there is neurologic problem with high dosage, and most of the other use usual high dosage, so 2 grams every 8 hours. It's not, we must avoid the use of higher dosage in our ICU patient. Next slide. For the meropenem, no adaptation is needed. Most of the other things that we must use prolonged infusion, and PK parameters are similar to those observed in non-obese individual patients. Next slide. For the Laptomycin, this is a lipophilic drug, and most of the authors think that we must use the total body weight. And with my Excel spreadsheet, you can see if you want 10 milligrams per kilogram for severe Staphylococcus bacteremia. So if the patient is at 130 kilograms, so the dose will be 1,300 milligrams per day. For this patient, there is a risk of muscle toxicity at high dosage. Next slide. For linezolid, most of the other things that we must use standard dosing for patients with high MIC bacteria. Perhaps you can add a dose, and it will be interesting to use 600 milligram every 8 hours. Next slide. For the ciprofloxacin, there are controversial data. Some people think that we must use adjusted body weight. Others think that we must use a total body weight. The dose of 800 milligram every 12 hours could be a good choice, and this is computed with this formula, and this is something like adjusted body weight. But some others think that dosing should be based on total body weight and not adjusted body weight. So this is a controversial issue. Next slide. We have realized a study in my ICU, and if we look at massive obesity ICU patient, and you can see the excess dosage on the right, lower dosage on the left. Next slide. And if we separate in 3 columns the patient, most of the time we observe overdosage for aminoglycosides because people used total body weight instead of adjusted body weight. And most of the intensivists do not really know what is adjusted body weight, so they use total body weight. We have observed a high dosage with cipro, colistin, metronidazole, cefotaxime. And for other drugs, we have observed too low dose with ceftazidime, ceftriaxone, and Laptomycin, and meropenem, etc. So this study was realized with massive obesity, patient with massive obesity, but with normal renal function. Because if the renal function is not normal, it's not the same thing. Next slide. So to conclude, this topic is not well known amongst intensivists. There are very few studies. It's difficult to extrapolate results from healthy obese patient to sick obese patient. The ICU sepsis is a complex situation because a patient could present a massive obesity and also renal dysfunction and septic shock with for some parameters there is an increase of elimination or a decrease of elimination. So this situation is very complex, and I think that the most complex situation is a obese ICU patient with septic shock and also acute kidney injury. So I think for all these reasons, because of the complexity, because of the lack of good data on this patient, the best thing is to monitor plasmatic concentration because we have only small sample sized study, or we have no data on this patient. Thank you for your attention.
Thank you, Bernard, for this great talk on a very difficult topic. I have one question for you. You say you measure urinary creatinine clearance, especially in these patients. And do you observe often this increased, this augmented renal clearance in these patients?
Yes.
It's described, but is it often observed in your clinical practice?
Yes, you are right. So the creatinine clearance formula are not overestimate the renal function in this patient, and so it is very important to collect the 24 hours a day, and effectively in this patient, sometimes we observe augmented renal clearance, and for this patient, the dosage must be increased.
Okay. Another question maybe, do you recommend to avoid oral formula for antibiotics in this population due to these issues in drug absorptions?
Claire, you know, for septic patient in ICU, the oral formula are not really predictable. So, to my knowledge, there are no data on oral antibiotics in ICU for obese patients. So, I think it will be not thing. At the early phase, it's better to use intravenous antibiotics.
Okay, even for a linezolid, for example, you would not recommend to switch to oral formula. I mean, in obese patients with these issues, these
Perhaps not at the early phase. I prefer to use intravenous linezolid, but after at day 3 or day 4, it could be possible to use this antibiotic.
Okay. There are questions from the audience. Some people want to know if the app you developed only come in French, or do you have an English version?
It is actually we try to translate all the guide, because this is only a part of a guide. And so I have realized with a friend the obese part of the guide, but all the guide will be translated. And perhaps it could be interesting to develop a separate application, especially for obese patients.
Okay. Other questions is sometime one of the attendee hesitate to use ideal body weight because the dose reductions can be very dramatic, and it tend to favor adjusted or lean body weight. What do you recommend?
For which drug?
I think for all drugs, there's no mention of a specific drugs, but for ideal body weight, we can imagine for hydrophilic drugs.
For some, I think for every patient, the ideal body weight must be calculated. It's okay, but so for aminoglycoside, we can use ideal body weight or adjusted body weight, but not the total body weight. So it depends on the drugs, and it's not possible to as I told, to use that lipophilic antibiotics. It's better to use total body weight, but fluoroquinolone and for fluoroquinolone, for Cipro, it's better to use adjusted body weight. So it's not possible to say that for hydrophilic antibiotics we can use adjusted body weight or ideal body weight, and for lipophilic antibiotics the total body weight, because it depends on the drug. So the best thing is to have a guide and to compute all the weights formulas and to do. But I think that for each drugs, the maximum dosage must be a limit. So for piperacillin, tazobactam, for it's most of the other things that 24 grams is the maximum. So for all this is the situation is complex because on the left there are the lack of efficacy, and on the right there are the toxicity, and so the situation is very complex, and so I think it's better to use TDM for this patient.
Yes. Okay, thank you very much, Bernard.